chapter 45. Okay, so just looking at the objectives, we're going to look at recommended childhood and adolescent immunizations. We're going to look at appropriate nursing assessments prior to administering an immunization. So there's some things we need to determine before we can even see if it's appropriate to give the immunization. We're going to compare and contrast some different injection sites and needle sizes that are appropriate for different immunizations. And we're going to look at vaccine safety and common side effects. Okay, so some of the benefits of immunizations. According to the CDC, immunizations protect toddlers less than 2 years of age from 14 serious illnesses, some of which can cause permanent disability and or death. One example, since they introduced the pneumococcal vaccine in 2000, there's been a reduction of meningitis and pneumonia by 35%. That's huge, okay? Just since they introduced that vaccine. Okay, immunization schedules are set up based on age, okay? So this is the 2012, but it's the same, it hasn't changed. Okay, so I just left this slide in here. These are the recommended immunizations, the schedule for infants. And I'm gonna point out the most important ones that you need to know, okay? So the first important one that you need to know is the schedule for at birth is hepatitis B. Hepatitis B is the only vaccine that we give from birth to 2 months of age. That is important for you to know. Okay. Now, the other thing that I want you to know is that a child, if they are on schedule with their immunizations, they should receive immunizations at 2, 4, and 6 months of age. It's not important for you to know what all of those immunizations are, because if you were to go work in pediatrics or in the emergency room, you would have a schedule that you could refer to when you're asking the family. But it is important for you to know they should have vaccines at 2, 4, and 6 months. Now I'm just going to tell you really quickly, they'll get their second dose of Hep B. You don't need to know this by heart, okay? But they'll get their second dose at 2 months of Hep B. They'll get diphtheria, tetanus, and pertussis at 2 months. So that's something to think about. An infant who's born up to 2 months, they haven't had their pertussis vaccine. They're going to be at a really high risk of developing that. Okay? They get polio vaccine, they get the Hib vaccine, the Haemophilus influenza vaccine, and they get rotavirus. This is a new one that protects against a GI condition that we talked about in the GI chapter, rotavirus. Then you can see at 4 months, they get another DTaP. They get their pneumococcal, the PCV, the Hib vaccine, polio, rotavirus again. At 6 months, they get their third Hep B. Okay? And then they get the whole list, the whole gamut of everything again. So I don't think it's important for you to memorize what they're getting at 2, 4, and 6 as much as it is to know they should be getting something then. Okay? So you do need to know Hep B, birth to 2 months. They get vaccines at 2, 4, and 6. Then the next thing that's very important for you to know is at 12 months. 12 months, as you can see, they're going to get MMR, that's measles, mumps, rubella. And they also can get varicella. We do not give those vaccines prior to 12 months because they are live viruses. And the babies up until 12 months, their immune systems are just too weak to give them live virus. And then just a little side note, nothing you need to memorize, but we can start giving the influenza vaccine at 6 months. We don't give it prior to 6 months. Okay?
So you're not giving the nasal injection?
We give injection. Yeah, and an infant at 6 months, they can't even understand. They can't sniff to do the nasal vaccine anyway. so it wouldn't be effective. Okay? All right. So everyone good on what you need to know from this slide? Then you can see we have another immunization schedule for children 7 to 18 years old. And just something that I want to mention, you might notice there's a lot of different colors on here and everything. Well, that's because we also have what's called a makeup schedule or a catching up schedule. So just something to think about if the child comes in and they're late on their vaccines for whatever reason, you may have to follow a different schedule. Okay? You can look it up. It's not something you need to memorize. But there's a couple things that are really important from this slide that you do need to know. The most important things are in the 11 to 12-year-old span. 11 to 12, they go in for their checkup before going into junior high. And all of the public schools require an updated Tdap. That's because the tetanus is only good, and pertussis is only good for 10 years. And then people need to be revaccinated. So they had it when they're younger. At 11 to 12, they need to be revaccinated. The other one, really important for you to know for 11 to 12 years, is the meningococcal vaccine. So that protects them against meningitis specifically and also pneumonia.
And that is also from 11 to 12.
11 to 12. The 11 to 12 checkup, that's what they should be getting.
For kids who, like their parents don't want to get them vaccinated for things, if they want to go to junior high, can they not have their kids vaccinated?
Yeah, they can
Yes,
sign a
exactly.
waiver.
Okay.
But then if there's an outbreak in the school, then that kid can't go to the school anymore. You'll get a note. Cause I always sign the waiver instead of going to get my kid's vaccination schedule. And then there's been a measles outbreak here. So then they got a letter saying you can't send your kid to school.
So you have to like go to a new school?
No, you can't go to school. You have to stay home.
Oh, like, okay.
Yeah, you just have to
Kids
stay
out of
home.
school.
They just
Yeah,
don't want
every
to
school is
spread it.
different. Private schools are different as well, but the public schools are really particular that you can't even sign up, register to start junior high unless you either have proof of the vaccine or a waiver that you filled out. Okay. Just another thing that's important too is the meningococcal vaccine. When they're 16 years old, they should have a booster for meningococcal. Because studies had shown that children that got the revaccination at 11 to 12, then they go away to college, okay, pretty soon after. And there was a higher rate of getting meningitis, so they decided to give it another booster shot, and the rates went down
At 16.
at 16. So that's the recommendation now.
You said Gardasil is available from 9 to 26.
Yes, and am I gonna be talking about that soon? Well, we can talk about that right now. I might be jumping ahead, I don't know, but that's okay. If I am, then we can skip it when we get to it. But the other vaccine that's available for children starting at 9 to 26 years old is for genital warts, or HPV, human papillomavirus. And I have kind of collected some pamphlets from the doctor's office, and I'll pass them around. Some of them are for HPV, some of them are for pertussis, but you can just kind of see what is out there for what they give to the parents for information. You see that it's recommended at the 11 to 12-year-old checkup only because people don't usually come in to get vaccines at 9. There's nothing scheduled for 9 years old. So unless they're coming in just for that, otherwise they recommend it at the 11 to 12-year-old checkup. And that is a dose of 3 shots, okay? There's actually 2 different brands on the market. You don't need to know this by heart, but it's Gardasil and Cervarix. Okay, those are the two brands that you'll see. And it's, you get your first dose, and then your second dose is 1 to 2 months later. And then the third dose is 6 months after the first dose. So it's a series of 3. The one thing I will mention about this vaccine is that it has caused fainting in a lot of children, especially females. And I read one study, they weren't sure if it was just because this is a really painful injection. They say that it burns really bad. So they don't know if the fainting was caused by the reaction to the pain of it or something that is in the vaccine itself. But it's been a really, really common side effect. So now when children get it, they have to lay down for 15 to 20 minutes after receiving it before leaving the office. Okay? It's available for boys and girls. Just like 2 to 3 years ago, they finally had insurance started covering it for boys. It didn't used to be covered. But they found that a lot of the oral and throat cancers that men are getting are related to HPV from oral sex. So they're wanting to protect the boys as well from getting it. Okay? I saw this one, this is from the CDC, that 1 in 100 sexually active adults, so this is adults, in the United States have genital warts.
1 in 100?
1 in 100. Because remember, a lot, especially in females, if it's really deep in the vaginal canal, they may not even know they have it. Okay? Okay, so I think I skipped ahead a little bit, but that's okay. We can. All right, so nursing assessments, things that we need to determine before we're going to give a vaccination. And actually, you know what, I'm sorry, I have a little note here. This is from the study guide. Let me just go back to this slide. Okay? Or I'm sorry, the first slide. Okay? Hold on, I think I'm missing something. I'm missing my kindergarten slide. Hold on 1 second. Give me a second. Well, let me just tell you. It'll be quicker. Okay, this is also important for you to know. So if you want to go back to the 0 to 6, you can write it down on the slide. Another thing that I want you to know is that for kindergarten, in order to get into kindergarten, you also need to either show proof of vaccinations or sign a waiver. And what they want to see that you have in kindergarten are the DTaP, so diphtheria, tetanus, and pertussis, polio, MMR, and they ask for varicella too. This is nothing that you need to know by heart, but just an interesting fact is they've been trying to combine vaccines so that we don't have to give so many injections to children. And there's a new one that's out, and it combines the DTaP, polio, and Hep B all in one injection. So that's really good. It's called Pediarix. So nothing you need to know by heart, just an interesting fact. Okay. So nursing assessment. What kind of things do we need to look at to determine if we can even give an immunization to a child? So there are some contraindications for giving immunizations, and this slide is very important for you to know. If the child has an active fever or a moderate illness, we would hold the vaccine. Do they have allergies to medications, foods, or any vaccine? We may or may not give it. It might be a contraindication. Some of the fillers that are in the immunizations, they may also be allergic to certain things. Like, for example, the flu vaccine, it has an egg derivative in it. So if somebody's allergic to eggs, then we may not give it to them, depending on what their allergy is. Have they had any previous adverse reactions to a vaccine in the past? It might be a contraindication, it depends. Does the child actively have cancer, leukemia, AIDS, any kind of immunodeficiency type of condition? Are they taking prednisone or steroids or chemotherapy? Have they had radiation in the last 3 months? Those are all contraindications. We would hold the vaccines. So there's lots of different conditions where children are taking prednisone, specifically asthma, right? So that's something that we wanna do a thorough assessment on before we just go ahead and give it. Okay, has the child received a blood transfusion or any blood product or immune globulin in the last year? Then it may be a contraindication, we might hold it. Is the child or teen pregnant or a chance they can become pregnant in the next few months? Because we don't want to give specifically the MMR vaccine. It's a live virus. If the baby develops rubella, right, or mom develops rubella and it crosses in the placenta, that can cause really severe defects. Has the child received any vaccine within the past 4 months? Now, obviously you saw in the infant that they have it scheduled every couple months, but this just means, for example, let's say they come in for a flu shot, and you're like, have you received anything in the last few months? Oh yeah, they got a couple different things, I don't remember what it is. They might have already gotten the flu shot, and they didn't remember. So it's not gonna hurt them to get it again, but depending on what the vaccine is that they just got, if it's not scheduled at that time, you don't necessarily want to give it again. Okay, so it's something it's not necessarily a contraindication, but it's something you would need to look further into. Okay, this slide is also very important for you to know. These are adverse reactions, so they're broken up into different types of reactions. The first one is a local reaction. If they have a local reaction, you're going to see redness or arrhythmia at the site, swelling, pain, induration at the site. And how would we take care of it? We could put ice packs to the area to decrease the swelling and help with the pain. Give an analgesic and just reassurance. Okay? That's a really common side effect to any kind of an injection, right? Even if we're giving an antibiotic, IM. That's something that can happen. Then we have systemic reactions. A systemic reaction would be a fever, fussiness, irritable, malaise, anorexia, and they may actually have an allergic reaction. Okay? And there's different ways that might manifest itself. If it's a local allergic reaction, they may develop a wheal, which is it looks like a round, like a hive. Okay? Urticaria, so it could be really itchy, and that can happen within minutes to hours after. So it might not be immediate. It could happen a couple hours later. A severe local reaction, they also would have warmth, arrhythmia, edema, and they may even develop petechiae in that site. And that can happen 2 to 8 hours later. So it's not necessarily immediate. Non-life-threatening, such as urticaria, within minutes. So the first two are things that may happen immediately, but not necessarily. And then if you have urticaria within minutes, just the itchiness, this is for an allergic, it's a type of allergic reaction. It's just showing you different types. Then we have life-threatening. Life-threatening would be anaphylaxis, encephalopathy, bacterial neuritis, chronic arthritis, thrombocytopenia, purpura, and death. Okay. It's very rare to have these type of life-threatening conditions. This is from the CDC. 1 out of every 1,000,000 doses of the DTaP result in anaphylaxis. And the anaphylaxis is treated with epinephrine, and the patient's fine. Okay. That would happen within minutes. Right. So the next couple of slides is just kind of showing you You do not need to know these by heart, okay? But it's just giving you an idea of how many immunizations we might be giving at once to a child. It's a lot, right? So for IM, for an infant, we would use a 5/8 inch needle, tiny little needle. And for infants, for IM, we always give in the vastus lateralis, right? They have a polio, a sub-Q polio. You can give that in the arm if you want, but we don't give IMs in the arm. They don't have enough muscle mass. That's really the reason why. So you don't need to know these by heart. It's just giving you an overview of, wow, that's a lot you're giving at once, right? Okay. Okay, so if we were giving all the doses, if they were late, this is where we would give for a child that's 12 months and older. So remember, we're adding, what two are we adding? The live? Varicella and MMR. Good. And then for a child 11 to 12, they automatically will get the Tdap and the meningococcal vaccine. By the way, the name, you need to know this too. This is important. The name of the meningococcal vaccine is called Menactra. M-E-N-A-C-T-R-A. M-E-N-A-C-T-R-A. Menactra. Okay? So that's the name of the meningococcal vaccine. Okay, so teaching, this is also important for you to know, okay? It's important as nurses for us to do a lot of education regarding vaccines because, why?
I don't think it causes autism.
A lot of people think it causes autism, and there was a study that was out and it was found to be bogus.
How do you like reason with people with that? Because people are like so all about it. Like, can you lead them to like a resource in the sense of like?
So you can. So look, I don't have the exact thing. I mean, I've read the studies online, but you can read them and then you can say, look, this was the original study, and then this is what they came out with after. This is what all the. You can go on American Academy of Pediatrics website, and they'll have all the information about vaccines. But it's sometimes hard to try and convince people otherwise, right? Especially when there are famous people that are backing it up. But I did look up. These are these are just interesting facts, so you don't need to write these down. But these are from both the CDC and the World Health Organization. Okay, so there are 13,000 to 20,000 cases of polio per year. Obviously, that's worldwide, okay, because it's pretty much eradicated in the United States. Measles causes 450 deaths per year. That's a lot. Measles. Worldwide. The HIV vaccine causes 600 deaths per year just for meningitis. Okay.
The vaccine?
No, I'm sorry. Haemophilus influenza. Haemophilus influenza. So if they don't get the HIV vaccine, they're at risk of getting Haemophilus influenza, which can cause meningitis. Pertussis, 9,000 deaths per year, mostly infants. Majority are infants. Varicella, 100 to 150 deaths per year. Rubella, they didn't have a statistic, but they said it's one of the leading causes of deafness and blindness worldwide. Okay, rubella. Hepatitis B, 1/3 of the infants that develop hepatitis B will have liver disease or liver cancer at some point in their life. So you can always give statistics to people and say, this is the statistics, and if your child's not vaccinated, they have this risk of getting these illnesses that can cause disability or death. Okay? And it's just important to teach them that vaccines stop diseases. That's proven, right? The more people that are vaccinated, the less chance they have of developing that disease and or spreading it. If we stop immunizing our children, then the diseases that we have essentially eradicated will return. Okay? They're already starting to. Look at pertussis, is really on the rise. And just kind of a little side note for you as a healthcare worker, if you take care of a patient that's diagnosed with pertussis, then if you want to still come to work, most of the places will force you to take antibiotics prophylactically to prevent yourself from developing.
Haven't
Even
we
though we've
been
been-
vaccinated though?
Yes,
So even if you've been vaccinated, you still have to take.
yes. Well, you don't have, they're gonna try to force you to. I'll just tell you that. I've been in that situation before, but I didn't take the antibiotics. I just wore a mask every day when I came to work, and I never got it. There are risks associated with vaccines, but they're very mild, and the severe reactions are extremely rare.
So even if we've had the vaccine and someone gets like polio or something tested for them, we're at high risk of getting it even though we've been vaccinated?
Yeah, and it also depends on when you were last vaccinated too, because you need boosters every 10 years for it. So they look at it and they'll say, okay, you were vaccinated, 8 years ago. So you have a potential that since you're taking care of other sick patients, they're saying, well, you might still have a risk, so they want you to prophylactically go on the antibiotics. You can decline still, but I'm just kind of throwing it out there because it's happened to me, and it may happen to you. Another thing that you can bring up is that, hey, if your kids get sick, then they're gonna miss school. One of the parents will probably have to miss work. So even if you're thinking, it's fine, I don't care if they get chicken pox, I'm good with that. Then think about, your child's gonna be suffering, they're gonna miss school, and you're gonna have to miss work, or someone's gonna have to take care of them while they're sick. So that's something else you can bring. I just put on, the CDC is, oh my gosh, I have to be careful when I go on that website because I can just look at it for hours. I get like addicted to it. I mean, literally. It's really cool. I mean, there's so many just neat statistics on there and pictures and everything. So, but you can go on there and check it out. You can refer your patients to it. And then there's this, you can watch this on your own, but this cdc.gov, there's an example that has on there about different common parental concerns and how you can answer them. And one of the pamphlets that I've been passing around, it's specifically about just immunizations in general, and it has like the most common parent questions and how you can respond to them. Yeah. So any questions? Okay, so let's do communicable diseases, and then you are done with lecture.
Which chapter is that?
It's 45 also. Okay, so we are going to, objective-wise, we're going to recognize common pediatric, infectious, and communicable diseases. And we're going to talk about the medical and nursing management of these diseases. Okay. So the first one we're going to look at is chickenpox, or varicella. Okay. Has anyone had chickenpox? I did. Yep. The vaccine didn't exist then. Okay. So I'm going to point out the most important things for you to know. Obviously, the incubation period and period of communicability, that's so hard. I can't even memorize that, okay? Because I just get so confused thinking of all the different conditions. So that's something that I think you can always look up if needed. But what is really important for you to know is the transmission. You need to know the transmission. It's direct contact, and it's also airborne. Okay? That's why it's so contagious. So incubation period, 2 to 3 weeks. You don't need to know that by heart. Period of communicability is 1 to 2 days before the rash appears until after all the lesions are crusted over. Okay, so don't need to know that by heart either. But just something to keep in mind is on all these diseases that we're going to be looking at, the most communicable time is typically before any of the major symptoms appear. And that's why it spreads so much, okay? So clinical manifestations you do need to know. So flu-like symptoms, and then they develop a very pruritic macule, so it's flat at first. The macule is flat. And then it progresses to a blister or a fluid-filled vesicle. And then once that vesicle pops, it crusts over, okay? It's so itchy, like unbearably itchy, that's usually how they pop, from scratching them. Okay, nursing intervention is also important for you to know. It's just supportive, it's a virus. So we give fluids, analgesics, antipyretic if they have a fever, and we want to help with the itching. So you can give Benadryl, an antihistamine. We give oatmeal bath. Aveeno, the brand Aveeno makes a really good oatmeal bath that helps with itching. Keep the fingernails short because of scratching, and you don't want them to get a secondary infection, staph or strep infection on top of that. There's also different lotions you can buy that tend to help, like calamine lotion is another one. Okay, the next one is Coxsackie virus or hand, foot, and mouth disease. The transmission is fecal, oral, and respiratory. So it's usually spread with younger children, toddlers, and preschoolers that are still putting stuff in their mouth, and they don't have good hand hygiene and washing their hands after going to the bathroom and stuff. Incubation period 3 to 6 days, and period of communicability, again, is 2 days before the rash appears and 2 days after it disappears. Okay? So what you really need to know from the slide is the transmission, the clinical manifestation, and nursing intervention. So clinical manifestation, they develop these lesions on the buccal surface of their cheeks, gums, tongue, hands, and feet. Nowhere else on the body. That's the only place. Nursing intervention is just supportive. So we usually will give analgesic because the blisters can really hurt in the mouth. We want to make sure they're drinking and eating enough. And contact precautions.
There's no virus, no vaccine.
No, there's no vaccine. It's really, really common. There's like outbreaks of it in daycares and preschools. It's really common. Okay. The next childhood condition is arrhythmia infectiosum, or fifth disease. Transmission is respiratory and through blood. Incubation is usually 1 to 3 weeks. Period of communicability is a week before symptoms. So you don't even know you have it and you're spreading it around, right? Okay, clinical manifestation and nursing intervention are the most important thing you need to know from the slide. So there's 3 phases. The first stage is a flu-like illness for 2 to 3 days, and then they have no symptoms for 1 to 7 days. It's just like a regular flu, nothing you would maybe even bring the baby in or the child into the doctor for, right? Then the next stage is they get a really bright red rash on their cheeks. It looks like they're slapped on their cheeks. They also have, they're really pale around their mouth and their lips, so circumoral pallor. And then they develop a lacy rash on their body. And that's what brings them into the doctor, once they get the rash, and their cheeks look like that. Then stage 3 lasts for 1 to 3 weeks until the rash fades completely. So nursing intervention, again, is just supportive, and they're on droplet precautions. They're in the hospital. A lot of times these patients are not treated in the hospital unless they're dehydrated or something else is going on. Usually they're treated at home. Okay, Haemophilus influenza, and that's what we give the HIV vaccine for, right? Transmission is contact or droplet. The incubation period is not known. And the period of communicability is 3 days from the onset of symptoms. So most important thing you need to know from the slide are clinical manifestations, nursing intervention. So they have just like a viral upper respiratory infection, so runny nose, cough, maybe sore throat. It can lead to meningitis, epiglottitis, pneumonia, and sepsis if not treated. So nursing intervention, we're going to do blood and cerebral spinal fluid cultures. Antibiotics are the big thing. You notice with the other ones we didn't treat with antibiotics, it's a virus, right? So we're treating this with antibiotics. That's a big difference. Droplet precautions until 24 hours after you start the antibiotics. Then they can come out of isolation after that. And then just supportive care.
Is epiglottitis the only progressive one that comes on super fast, or do they go from viral upper respiratory infection to full-blown meningitis?
They can get meningitis really quick too. I've seen it happen really quick.
Pneumonia and sepsis also? Or will those be more natural?
You can't, I mean, everyone's different. So it can be really immediate. It can take a few days after. Yeah. Okay, so the next one is measles or rubeola. So this transmission is contact and airborne. Incubation period is 1 to 3 weeks. Period of communicability, 3 to 5 days before the rash, 4 days after it appears. So what you need to know though are the clinical manifestations and nursing interventions. So they have a very high fever. Coryza, that's an inflammation of the nasal mucous membranes in the nose, nasal mucosa. They have a cough. They have something called Koplik spots on their buccal mucosa, and there's a picture of it down here, and they look like white spots. Okay. They have a red, blotchy maculopapular rash that begins on the face. So that's important in diagnosing. It's really important to ask if your patient comes in with a rash. Did you ask the parents, do you remember where it started? Okay, so it starts on the face. It's a virus, so we just are supporting them, giving analgesics, antipyretics, fluids. Meningococcus is the next one. And transmission is contact. Incubation period 1 to 10 days, and communicability until 24 hours after you start antibiotics. So what you need to know again, clinical manifestations, nursing interventions. So they have flu-like symptoms, prostration, remember they may have neck pain, they may become really stiff, especially an infant. They develop a petechial rash, and it can turn into purpura. These are purpura if the child becomes septic. I will just say, I think I may have told you, I've had 3 patients with this, 2 of which passed away because of the sepsis. So once they develop the purpura, it's pretty much like not good. We call the family in, we tell them it doesn't look good at this point. Nursing interventions, we treat it with penicillin. Fluids maintain the airway, which is important. Droplet precautions until 24 hours after they start the antibiotics. Mumps is contact, transmitted by contact. Incubation period is usually 2 to 3 weeks. Communicability 1 to 2 days before they have parotid gland swelling and 9 days after the swelling starts. So you can see this is a perfect picture. See how swollen those parotid glands are? Clinical manifestations, malaise, low-grade fever, pain with swallowing, and then they have their parotid glands swell, really, really large. It can cause orchitis, which can lead to sterility. So that would be another important teaching point if the parent doesn't want to get MMR, especially for a boy. You can tell them if they get mumps, they can become sterile and never be able to have children because of it. So that's an important teaching point. Nursing intervention is supportive. If they're in the hospital, droplet isolation. Okay, pertussis or whooping cough. The transmission is droplet and contact. 7 to 10 days is the incubation period. The period of communicability, I do want you to know this one from the slide. They're most contagious before the paroxysmal cough stage, which we're going to talk about. Paroxysmal just means an intensification of. Okay? So that's when they're most contagious, before that, the whooping cough really starts. So clinical manifestations are in 3 different stages, and you don't need to know the names of the stages. I just want you to know they go through stages. The first stage is really mild. It's just an upper respiratory infection for 1 to 2 weeks. So runny nose, cough, it doesn't seem very bad. Nothing you would probably bring your child to the doctor for. Okay? And remember, that's when they're most contagious. Okay? Then, once they, it progresses, and that can happen in 1 to 6 weeks, or it lasts 1 to 6 weeks, I'm sorry. From that point is the paroxysmal coughing stage. That's the whooping cough. So it's just, they are coughing so much, they can't stop coughing. It usually causes vomiting. They can't breathe, they turn bright red. It's really sad, the little infants, when they have it, because they can't even breathe. Then they have a convalescent stage for up to 6 weeks, and they'll say that they're cured from it once the coughing stops completely. Okay? But they can have this whooping cough stage for 1 to 6 weeks. And obviously if they have it that bad, they have to be in the hospital because they can't even eat or drink anything. They can't keep anything down. So they would be on IV fluids or maybe TPN if needed. Nursing interventions. We give a macrolide antibiotic. Also treat any close contacts prophylactically. So remember, if we get a patient that comes in, typically they're coming in the paroxysmal stage. So they're really not contagious at that point. So for a healthcare provider, we don't have to, that's why I didn't take the antibiotics, because I'm like, they're not really contagious right now. But for someone, a parent or siblings that have been in close contact, they've been with them in that communicability stage, so they really should take the antibiotics.
Friends and kids and stuff.
Yeah,
Like
friends.
playmates and stuff, so.
Yeah,
their
if they've been in
parents.
close
Okay.
contact, then it's a communicable disease. So the Department of Health will, if they report it, and then they will seek out any close contacts and make sure that they're getting antibiotics. But macrolide antibiotics, that would be like the most common would be erythromycin, which that causes a lot of side effects, a lot of GI discomfort, diarrhea, cramping, so it's not fun. Corticosteroids, so we want to decrease, because of all that coughing and just from the virus itself, it's causing inflammation, so we want to decrease the inflammation, open up the airways as much as possible, supportive treatment, droplet isolation until 7 days after the antibiotics are started. So remember, Normally it's like 24 hours after. They're isolated for 7 days. Okay?
Once someone has the pertussis, they will never get it again, will they? Or can they be exposed to it?
Your body will build up immunity to it once you have it, but you can get it. Usually if you get it again, it's not as severe of a form. It's more mild. But just like anything, even if you're vaccinated, you can still get it, right?
If they're not contagious, why are they on isolation for 7 days? If they're positive.
Well, the thing is, that's not the strongest period of communicability, but they still, they're most contagious then. And it's just such a devastating condition because it lasts so long. So they want to make sure no one else gets it. It's not like something that will last a week and you're better. This is like a couple months it can last. Okay, so the next one is roseola. Very, very, very common. Okay, transmitted through respiratory secretions. Incubation period 9 to 10 days. Period of communicability, actually, once you are exposed to it, you can shed the virus forever.
And that's why it's by healthy individuals.
Yes.
Healthy.
Yes. Clinical manifestations, a sudden high fever, and I'm talking like really high. It's like 102 or higher. Okay? And they have no other upper respiratory symptoms. It doesn't seem like they have a urinary infection, nothing, right? Just boom, a really high fever. Then, once the fever stops, they develop a rash, okay? It's a really pale pink maculopapular rash, and it starts on the trunk, so that's important to know. It starts on the trunk, then it spreads to the face, the extremities. It starts on the trunk. Nursing intervention is just supportive. Okay? Really common. My daughter actually had it, and she had this really high fever. Of course, I worked in oncology, so of course I was like thinking, really something really bad, and so I brought her right in. They did a full septic workup. They're like, nothing. She has nothing. It's really weird. I don't know why she has fevers. We'll have to wait and see. So finally, I think it was like almost a week. She had these high fevers every day, and the fever stopped. And I'm like, oh, okay, the fever stopped, that's good. And then I went to change her diaper, and I saw the rash, and I'm like, yeah! I was so excited. I'm like, roseola! I called the doctor, she has roseola! Like, okay, good, you quit bugging us now.
Do they treat that? They treat the high fever, right? With
Yeah,
like
you
Motrin
alternate with Motrin and Tylenol. Because it's, yeah.
We kind of do them both at the same time.
You alternate them.
When you say alternate, you're doing Tylenol every 4
And then Motrin. Yeah, yes. Because you don't want to be loading them up on just Motrin or just Tylenol. If you're giving it around the clock, you always will be
We don't give both
altering.
Usually they'll give Motrin 4 hours later, Tylenol 4 hours later, Motrin.
Yeah,
4 hours
you
later,
just
Tylenol,
alternate.
4 hours
So
later,
when the next
Motrin.
dose is due, you give Motrin. Next dose is due, you give Tylenol. So just alternating it. Okay, rotavirus. This is fecal oral transmission, incubation 2 to 4 days. If you notice, like the GI conditions, the incubation period is a lot shorter than the respiratory type, right? Period of communicability, of course, is before any symptoms appear, up to 21 days after symptoms appear. Okay? Clinical manifestations, low-grade fever, vomiting, watery diarrhea. And when I say watery diarrhea, I am saying, like, you're literally changing a full diaper every 10 to 15 minutes.
foul.
And it smells really bad. And this is a situation, remember we talked about with the fluid and electrolyte lecture? So this is where you would do replacement therapy, IV therapy, on top of their maintenance, because they're losing so much. So fluid and electrolyte replacement, contact isolation. Okay?
When it's skin breakdown, do you leave the shoe?
Yes, skin breakdown, definitely. That's a good point. I should add that to the slide because we use like a skin barrier cream on there because, yeah, they're having just constant watery diarrhea.
Is there a test for this? Like diagnostic?
Yeah,
Or they just, okay.
yeah.
Is
Oh,
it
yeah.
stool
They'll
culture
send
or
the stool.
blood?
They'll send the stool to test it. And remember, this is what we have a vaccine for now. It's an oral vaccine called Rotarix. So that's great. They give it at 2, 4, and 6 months. You don't need to know that by heart, but okay. Last one. Rubella, otherwise known as German measles. So transmission is droplet and contact. Incubation period is 2 to 3 weeks. Period of communicability 7 days before and 7 days after the rash appears. So what you need to know, again, clinical manifestations, nursing interventions. So they get a pink maculopapular rash. It starts on the face. Starts on the face. They have a low-grade fever, upper respiratory infection symptoms, lymphadenopathy. They have something called Forstheimer spots, and you can see on their soft palate, see these red, they almost look like purpura, okay, or petechiae. Nursing interventions are just supportive and droplet and contact isolation. So I know it's a lot, and these all kind of like, oh my gosh, they all sound the same. Just really focus on the clinical manifestation, the nursing intervention.
And the transmission.
Yes, transmission is important too, because you need to know nursing interventions are going to be related to how it's transmitted. Right? So any questions?
There were a few that under transmission from mumps or pneumococcal that said transmission was contact, but then nursing intervention said droplet. Is that matter, or is
Yes.
there a reason for that?
Yeah, it's actually both. For meningococcis, it is contact and droplet isolation. And what was the other one you're asking?
Mumps, the same thing.
Yes, contact and droplet isolation. Okay.